Okay, good evening, everyone. And
Gaurav is there. Just a second, Gaurav. I think Gaurav.
Soban, you can check. Meanwhile, let's start the proceedings.
Yeah. Okay. Okay.
Okay, good evening, everyone. And it's actually an honor and privilege that
This meeting is being recorded.
I am given this opportunity to introduce this inaugural event by the Indian Society for Study of Pain Odisha branch, which is a pretty young branch in its nascent stages. In fact, we are about to conduct a first national conference early next year, but it's got postponed. But nevertheless, due to the efforts of our office bearers, so somehow we managed to start this inaugural edition, and because now we have all come to realize that this pandemic is going to stay with us for quite some time, and academics should not take a backseat. We can do our bit sitting at in the comfort of our homes. And I welcome Dr. Rajendra. I can see Dr. Rajendra here. So anyway, good evening once again to all who are present and all who are subsequently about to join. And it's a really very interesting and updated session, I must add, because ultrasound in pain management, I imagine maybe a decade back, all these things would have seemed like science fiction, but now we are seeing it hands-on. Our colleagues and a lot of upcoming talented people doing really fantastic stuff. So they've used the probe like anything, and quite a few of the exponents are there in the meeting. So in that way, we are very fortunate. Before inviting and introducing the speakers, for those who have come in now, I just like to mention one point that to make the meeting very seamless and interruption free, whenever a speaker is speaking and you have any issues with any of the stuff, you can just type in your issues or raise a hand. And if there is any question pertaining to the topic, that can also be taken up later. This is in the interest of time, because if we keep interrupting, then the flow of the session definitely gets affected. And of course, the speakers for the evening need no introduction, but it is my duty to introduce them very briefly. First and foremost was my teacher, and probably one of the most energetic persons, not only anesthesiologists, one of the most energetic persons I've seen. Event, any occasion, at any notice, any short notice, she is always very sportive and game for any type of activities which is for the betterment of any academic society. So she'll be our first speaker. Then that will be followed by Dr. Gaurav. Dr. Gaurav completed his DNB and pain fellowship in Kolkata, and subsequently joined AMRI Hospital and Care Hospital. Presently is working in Care Hospital. He's also the treasurer of the ISSP Bhubaneswar, and also he is the secretary of the ISA Bhubaneswar City branch. The concluding speaker would be Professor Ritesh Roy, who is presently the academic director at Care Hospital and the head of department anesthesia. He is also the vice president of the ISSP, and is also the president of the ISA Bhubaneswar City branch. So he will be the concluding speaker, and his topic is a very interesting one. So I'll not. You have all seen the posters, but I assure you it's a very interesting topic, because actually a work which has been published. So, and he's the person who was leading the team, so he'll be the best person to talk about it. So I guess I have talked enough, and we should move to the business end of the meeting. And it's again my honor to invite our founder president, Professor Nivedita Pani, for the first lecture of the evening. And I take this occasion to invite Our chairperson, Dr. Saroj Sahu, has just joined us. The other chairperson is Professor P.K. Misra, sir had already joined us. And we are still waiting for Dr. Siddharth Mahanti.
He has also joined us.
He's also joined us. Okay. Welcome to all the chairpersons, and thank you once again for finding time to grace this occasion. So I'll hand over the proceedings to Professor Pandey. Ma'am.
Thank you, Jita, for such nice, praiseworthy and things about me. Actually, I am not well. Suddenly, I had a very catch in my back, which is a very constant perennial problem with me. Anyway, thank you so much. As per your advice, I have taken the medicine. I hope I should be all right. Anyway, I'm just going to share my slide. Is my slide visible?
Yes, madam, it's visible. Yes, madam, it's visible.
Yeah. The topic which has been assigned to me is the role of pain clinic and pain management services in present day scenario. What is pain clinic? A pain clinic is a place of convergence for all these patients, irrespective of the etiology of the pain, medical, surgical,
please,
orthopedics, traumatic, oncological, or whatever.
Full screen.
Madam, please make it PPT mode. Full screen, PPT mode.
Yeah, I put it in the PPT mode.
No.
Make it full screen.
PPT madam, jo slideshow option ta ko maran. Slideshow option
ta. Tole right hand corner re 70%
अच्छी नाले ऊपर अच्छी
slideshow option ta thibo madam seta mar.
Is it okay?
No.
Not yet.
Slideshow.
ऊपर
वो मारी थी तो. Slide. Just a minute.
No.
Okay?
No,
madam. Hey nahi. Madam, screen ro tamre.
जो टॉप पर ही ची तापरे तो ही क्लिक करची मु.
मैडम आवतरे क्लिक करंतु हे नहीं.
और डबल क्लिक.
Okay?
No. किमा ऊपर जो अच्छी फाइल होम इंसर्ट डिजाइन ट्रांजिशन.
मैडम से जोड़ी 75% लिखा है जी ता साइड.
सेटिंग जा स्लाइड शो और ऊपर को. Your cursor is there. और राइट.
जाओ जी 1 मिनट.
हां ता ऊपर जो स्लाइड शो लिखा है जी.
हां स्लाइड शो
लिखा है एनिमेशन स्लाइड शो रिव्यू.
कर्सर आउट के ऊपर को गले हबो. हां बस. स्लाइड शो यस सेटा रिव्यू.
ना
रिव्यू नहीं स्लाइड शो
तार लेफ्ट आड़ को आसंदु से स्लाइड शो तळ को कर्सर आनी कि लेफ्ट को जानतु
और बांकु नो लेफ्ट को सेटअप स्लाइड शो.
जस्ट अ मिनिट मु तो तळे ही तो मु सबले करे देखियो.
तळे
आसला
तळे काई के होनी ना. हां एबे आसला.
Okay.
So what is a pain clinic? A pain clinic is a place of convergence for all these patients, irrespective of the etiology of the pain, medical, surgical, orthopedics, traumatic, oncological, or whatever. The pain clinic are used to treat the acute and chronic pain. Usually whom it is headed? It is generally headed by the anesthetist in conjunction with other specialists. Who are they? Rheumatologist, neurologist, neurosurgery, psychiatry, and other discipline. Whom will give the pain service? Inpatient consultation like medical, acute pain time like post-operative, and chronic pain type like multidisciplinary. So as you know, pain is a more terrible lord of mankind than even death itself. You cannot believe 15 to 20% of population have acute pain like medical and surgical emergencies, post-operative pain, after accidents and injuries, and 25 to 30% of all population have pain in chronic backache, cancer, migraines, arthritis, and neuropathic pain. What kind of patient generally get incapacitating pain of more than a month duration needs special attention? If any of these following questionnaire is fact file is yes, then the patient should have in pain consultation service like, are you unable to work because of pain? Does the pain restrict your daily activities? Have you had pain lasting more than 3 months? Does your pain affect your relationship with others? Are you feeling depressed because of unrelieved pain? Nothing is working. You will definitely get benefit if they will come to the pain clinic. What is the role of the pain clinic? Alleviation of the pain. Alleviation of physical and behavioral. Reduction of the disability and restoration of the function. Rationalization of the medicine. Reduction of the utilization of the healthcare services, including consultation in the primary and secondary care, surgical operation, and treatment such as physiotherapy. What are the types of pain clinic we have seen? One is the independent pain clinic. Independent pain clinic will require higher financial, but it provides higher income return. One can promote their own institution and have total control of the institution. Hospital-based pain clinic, it is a part of the multi-specialty, hence it requires less investment and easy to manage. One can utilize the existing facilities. Foot approach. A singularity means a single practitioner, acupuncturist, chiropractor, seeing and treating the patient without regular input from other practitioners. Multimodality, practitioners of different specialty treating the patient in a similar location without regular structured discussion of the patient by all practitioners. Best is a multidisciplinary. Why? The practitioner of the multiple different specialties, including a minimum of one representative from each of the following field, like a physician, physical therapy, psychological, treat patient together as a team. Often present are occupational therapy, acupuncture, nursing, and chiropractic. So definitely I will comment multidisciplinary is the best. What's our diagnostic? We take the history, physical examination by the staff physician, psychological testing and interpretation, psychological interview like interview the patient, interview the family members, laboratory like clinical laboratory, radiography, computer tomography, magnetic resonance imaging, bone scan, etc. Therapeutic like pharmacological, analgesic, psychotropic, anti-inflammatory, muscle relaxant, drug detoxification. Cognitive like coping strategies, biofeedback, relaxation. Medical modalities like nerve blocks, steroid injection, neurosurgical ablation, neurolysis, neural stimulation. Physical modalities, training and range of motion exercise, heat, ultrasound, vocational training, and other services. So as everybody knows, pain treatment continuum start with over-the-counter medication, NSAID, adjuvant medication, weak opioid, then you go to the strong opioid, then intervention of the nerve block, then spinal anesthesia, then neuroablation, like this pain control. What do we need to build a successful pain clinic? Number one, good ethics, good training, good business plan. Location, we have to find out the location, budgeting, marketing and advertising, availability, reasonable fee schedule, and charity work. What do you mean by the good training? Get a training in stages like lumbar injection, radiofrequency procedures, cervical procedure, disc procedure, spinal implants like spinal cord stimulators, intrathecal drug delivery system, vertebroplasty, and kyphoplasty. When you have to make an algorithm for all the treatment of all broad diagnosis and pain management. When in doubt, confirm by imaging and use of contrast site. When you have in doubt, don't inject. Always take the consultation advice. Where it should be the location. It should know the demography where the patient are coming from. Location should be convenient to public transportation, close vicinity of the other referring physician, preferably on the lower level or provision of the elevator. Because it is always the pain persons, it is difficult like to climb the upstairs. Suppose by mistake the elevator will not work. So it is better to always go on the lower level on the provision. How much should be the area? 1600 to 2000 square feet. Good patient flow, waiting room, 2 to 3 patient exam room, procedural room, storage room, consulting room, rest room, break room, and reception room. So you should have a waiting room, 2 to 3 patient examination room, and procedure room where you can do all the procedures. Consulting room, you should do the consultation. Support service, information technology for what? Patient booking, medical records. Out. Next come. What is the pharmacy you should keep? Local guidelines of prescribed information sheets for patient about medication and their uses are helpful. Centers that provide intrathecal drug delivery need the support of the sterile preparation unit. What are the equipment it should be? Fluoroscope, C-arm, RF generator, ozone generator, portable infusion devices, PNS, ultrasonography, pulse oximeter, ECG, autoclave. These all are high standard, but whatever it may be, if you have most important is the C-arm is very important. And if you are going to a higher centers, you can have all this facility, definitely betterment for the patient. Disposables, what are the disposables you should keep? Needles, syringe, antiseptic solution, medication, alcohol swabs, band-aid, injection trays. What should be a staffing pattern? Medical practitioners like anesthetist in conjunction with whom? Rheumatologist, neurologist, neurosurgery, psychiatry and other discipline, nurse specialty and nurse consultant, clinical psychologist, physiotherapist, rehabilitation medical specialist, occupational health specialist, psychiatrist, palliative care physician, occupational therapist, pharmacist, vocational counselor, and employment advisor. This I'm telling you in a broader outlook. You may not have all, but few at least you have to keep which are important. But in a bigger setup, definitely you should try to keep all the people so that it will be definitely benefit for the patient. As you know, area of the special requirement where you require, if the pain management service for the patient with cancer, as you know, all the step 1, step 2, step 3, I'm not going to detail. Step 1, non-opioid adjuvant therapy. Step 2, opioid mild to moderate pain, non-opioid plus adjuvant therapy. Step 3, opioids for moderate to severe pain, non-opioid plus adjuvant therapy. Other area where you require special requirement for the pain therapy, like children, elderly, learning difficulty. Actually, it is very, very difficult for learning difficulties to assess their pain and how to treat them also. Physical impairment, diverse ethnic background, non-English speakers. There is a need for special multidisciplinary clinic for certain person like sickle cell disease and chronic pelvic pain. When you are making a pain clinic, you must have a definitely audit should be there. Regular evaluation and audit of outcomes and complication of the treatment, you must keep it. And also there should be a culture that's supportive of the research into persistent pain. Why there is pain? Even if I am treating, why there is constant pain? Especially the conduct of well-designed clinical trials, including multicentric Sundays. And should have an organization and association. You are making such a big pain clinic. You should properly organize, and administration capacity should be there also. Patient information has to be maintained. Like patient should be made aware of the source of support. What is a pulse for the good practice? You must develop an algorithm for the particular pain, learn 3-dimensional view concept of the fluoroscopy, have experienced physician present when performing procedure for the first time. No, don't have the ego problems. Please, you are doing something, you can take the help of others. Once you are confident, then you can start it. Know all about your equipments, update the recent trend. What is the recent trend? What is the recent management? Always feel about that. The modern pain relief clinic is the interventional pain specialist nowadays. They are doing excellent work. extensive mandatory use of the fluoroscopy for the pinpoint accuracy of the nerve block is very important. Use of a safer technique like radio frequency for denervation instead of neurolytic agent. Use of the implants like spinal cord stimulator for treating the pain of chronic backache, refractory angina, or back surgery. To ensure accuracy, non-ionic radiopaque dye is injected under fluoroscopy to ensure that the injection is going for other types of the chronic pain and cancer pain. Use a procedure like discography, pinpoints, interventional discs to be removed, thereby avoiding failure of back surgery. Development of needle procedure like IDET and nucleoplasty to replace the major invasive back surgery. What is the problems peculiar to our country? By saying this, I will wind up. Because non-availability of the vital analgesic that preservative-free forms, bureaucratic hurdles for procuring opioids, their license and transport license, lackadaisical response from pharmaceutical industry, lack of awareness among other consultants with pain as a new and different specialty, lack of medical insurance. You know, the insurance company are not aware of the most of this new procedure, and lot of justification we have to give in. See, we are doing this. This is the ablation therapy. I am going to be all right. So the insurance company has to pay for it. It is a very, very troublesome when we have to experience them. Thank you. You are living pain. Enjoy the journey.
Thank you, madam, for the nice presentation. It was nice to hear about the present scenarios. Now, our next speaker will be Dr. Gaurav. Madam will be taking up the questions at the last. Whatever will be the questions from the different participants, they will be putting up in the chat box and will be taking up it in the last. And thank you very much, madam, for the nice presentation. And we'll look forward for more inputs from you in near future. Now I welcome Dr. Gaurav. Please go ahead. Thank you.
A very good evening, and thank you, Shobhan Bhai, for initiating this particular webinar series. And we are doing it for the first time. We'll surely continue doing this for ISSP Bhubaneswar. Thank you, ma'am, for a wonderful explanation about plain clinic setup and what to do, what not to do. We'll continue with our topic of using image for pain intervention. The most common image which was used up till now was fluoroscopy for all chronic pain interventions, and for acute pain interventions we were using the nerve stimulator and some landmark techniques we were using. But with the advent of technology and ultrasound, we can use the ultrasonography for various acute pain blocks, and it has become a norm now that ultrasound is used for various acute pain block. For chronic pain, we use them for nerve blockades like ilioinguinal, LFCN, suprascapular, pudendal, intercostal, epidurals, selective nerve roots, and especially median branch block. Coming to intra-articular injections, we are using intra-articular injections for ultrasound for intra-articular injections, also for muscular injections, trigger point injections, and also we are combining ultrasonography with fluoroscopy for our chronic pain blockades nowadays. I want to declare that there is no conflict of interest and no promotion of any particular brand or product. There was no financial support from anyone. These are my references for this today's presentation. When I started using ultrasound for pain blockades, probably in 2010, while using ultrasound, it was like Kala Akshar Bhais Barabar, because we could not make out anything from what is on the screen. We could not differentiate what is there on the screen. So we needed to inform ourselves, or we need to learn everything what is required to identify what is there on the screen, because it is a 2D image and it shows you just a small part of what you are seeing in front of you. So we need to know about the machine, about our equipment. We need to know how to optimize the image or acquire an image and optimize an image, and how to use the needle and how to enhance our needle visibility. And then the third point which we'll be discussing is the injection and delivery of the local anesthetic or the drug, whatever you want to give. I will discuss the relevant physics as we go through the presentation. And at the end, we can hit the eye or our target. So first we'll know our equipment, and these are the probe types we commonly use in our ultrasound machine for basically pain management. There are other probes which are used for echocardiography, cardiac echocardiography, but these are the three probes which are used for pain intervention. Sorry. So this is the high frequency linear probe, the straight one. And this is also a hockey stick probe, which is a high frequency linear probe with a smaller footprint. So these two probes are usually, this hockey stick probe is usually used for pediatric population and a very superficial above clavicle blocks also. But the linear probe is used for all our superficial blockades and superficial structure interventions. And the curvilinear probe is a low frequency probe which is used for blockade of the deeper structures, which to visualize the deeper structures in the body. The frequency is directly proportional to the resolution. So what is the resolution? Resolution is the clarity of the image that we see. The clarity of the image, and resolution is basically the discrimination of fine details of the structures that we are seeing. And penetration of the probe or the ultrasound waves is determines the depth of the beam. That is, as deep it goes, you can see that the low frequency probe can penetrate more and we can see to a greater depths. But the high frequency probe cannot penetrate deeper and we can see superficial structures better. So the frequency is inversely proportional to the penetration or depth of the structures that we can see. Coming to machine or the knowledge that we commonly use this particular presentation as, all machines have different interface. So we have to have a knowledge of our own machine and the knowledge of the machine. Maybe we can ask for a demonstration from the company we are using the machine from. And we need to identify these 5-6 points. We need to identify how to enter the demography of the patient, what are the modes and probes we are using, what is the depth, what is the depth that is set, and what is our target depth, how to use gain, how to use Doppler, color Doppler for our interventions, and what are the other operating modes present. Coming to buttons, this is the power button, first button, that is a power button. We need to switch on the machine. How to switch on the machine, that is a power button. Various mode buttons are here, the M mode, the Doppler mode, the color mode, and the 2D mode, which we'll discuss further in the presentation. This is the gain button. There are toggle buttons on each machine, which the function of the toggle machine is shown on the lower part of the screen. This is the cursor which you can use, and these are the caliper buttons, calculation buttons, and various save and review buttons. The demography entry can be done by using the patient button, which is commonly present as with the name of patient, and you can enter all the demography details in such a screen which appears after pressing that button. Coming to exam, there are presets always saved by the company, which you can use by using this exam button. And some machines have probes attached to it, and the exam button will give you the choice of the probes also. This machine has two probes attached in the change of probe machine button. Probe button is outside the keyboard. So you can use some presets like obstetrics and gynecological examination, abdominal ultrasound, nerve. So we usually use the MSK or the nerve mode preset for our pain interventions. The most common mode that is used is the 2D mode. Here you can see I'm showing the spine ultrasound here. So we use the 2D mode to see our structures on the screen. Using the color button, we can identify vessels in our screen or in our path. If you press the color button, there is a box appearing on the screen, and it will show you colors on the screen. So whatever is coming towards the probe appears red. Whatever is going away from the probe appears blue. So I just wanted to show you that the same vessel, I'm scanning the same vessel, it is showing red and blue also. So it is just the orientation of the probe with the vessel and the flow that changes the color. The Doppler also can be used to identify the vessels. So an artery will show a pulsatile flow and a vein will show a continuous flow. So Doppler can also be used for vessels. The M mode we usually use to mark the center points for our injections, especially for the spine interventions. The M mode is commonly also used for other focus ultrasound for focus, like the lung ultrasound, gastric ultrasound, and we also use for the IVC measurement. So the M mode is very helpful in these things. How the depth changes the image. So when we increase the depth, you can see how the image is changing. So you have to keep the target structure at the 2/3 of the screen. That is a 2/3 part of the screen. You'll see later in the presentation how it enhances your visibility. How the gain changes your visibility on the screen. So when you see the screen bright, you can see how it is changing. So first it was changing the near gain. I'll show you again. So first the near gain is increased and the structure on the upper part of the screen is getting whiter. The second is the far gain, and this is the total gain. So how the gain is changing the visibility. Review button here can help you review whatever you have saved, and the save and clip button. The clip button helps you in saving longer clips, and the save button helps you in saving an image on the screen. Coming to image acquisition and optimization. Before scanning, we need to identify this particular important point, that is the probe marker. So the probe marker, in all the probes there is a probe marker, which could be a dot, which could be a line, which could be a light, a small LED light. So we have to identify this probe marker first, and then we have to identify that the probe marker is on which side of the screen. So we usually keep it on the left upper hand corner for our interventions, and we usually keep the probe marker cephalad or medial. It is a accepted rule to keep the probe cephalad or medial side of the patient. So the idea is to
Hello. Hello. Hello.
I think Gaurav
Yeah.
put some issues.
I think we have lost him.
Yeah,
Maybe network problem.
yeah,
Yeah, might be, sir.
just a second.
Hello.
Yeah,
Sorry,
Gaurav is back. Gaurav is back.
sorry, I got disconnected. Sorry.
Okay.
Yeah, I was telling about out of plane. The advantage of out of plane needling is similar to other. It is very similar to other approaches, like we were using the new nerve stimulator method. It has a shorter needle path, and we can use it for catheter placements for longer duration blocks. The disadvantage is the needle path is unimaged, and there is a risk of crossing other structures without recognizing what we are crossing. The in-plane has more is more advantageous and is more preferred method because the direct visualization of needle course is there. The disadvantage of in-plane is it creates a false sense of security when the needle tip is not correctly identified, and the needle path might be longer and more structure crossed. The long axis view has an advantage. The target is visualized throughout the course, like you can see in the image. The disadvantage is distinct structures cannot be visualized. In a short axis view, the distinct structures, the distinct target structure and the surrounding has been identified in a short axis view. But disadvantage is that the target spread is not visualized throughout the course of the target structure. Coming to gain, the physics related to gain is that the gain has an auto gain time gain compensation that affects the brightness of the image. So like I was telling, if you keep your target structure at a 2/3 of the screen that you can see here, that is the focal zone where the automatic time gain compensation by the machine is done. So it increases the focusing or the attenuation effect, that is the clarity of the image at this particular area, and it is inversely proportional to the penetration or the depth. So the clarity or the attenuation is better in a high frequency probe and at a superficial structures or closer structures, but it is poorer in the low frequency probe and the greater depths. The next important point is echogenicity, which is affected by the acoustic impedance of the tissue. What is the acoustic impedance? It is the power of the tissue for absorption of the ultrasound image and reflection of the ultrasound image back to the probe. So what the ultrasound is doing, it is converting electrical energy into a mechanical sound wave energy, which goes into the body. It hits the various tissues. Some of the sound wave is absorbed and some is reflected back to the probe, which is again converted into electrical energy, and then it is shown on the screen after it is converted into mechanical energy. So the various structures, like here, the air has the lowest and bone has the highest acoustic impedance. So these things change the echogenicity, and you can see how anechoic it is. The anechoic is it is lower in echogenicity than its surrounding structure, and it becomes very totally black, and the veins and arteries are anechoic. We can differentiate using the pulsatile and the pulsatile nature of the arteries and compressible nature of the veins. Hypoechoic structures are lower in echogenicity than its surrounding structure. Isoecho is similar. Hyperechoic is it reflects more whiter than the surrounding structure. And reflective images is like the lung pleura. We can see it reflects the air mucosal interface reflects. There is a white line and everything is black below it. Also the bones show a reflective image on the screen. Next point is needle visibility. How to optimize the needle visibility. So what the ultrasound probe does is takes a 2D image. It is a credit card like image on the tissue below the probe. So we need to get our needle in an angle of 45 degrees. That is the best way to identify a needle under the probe in our screen. So the more the needle is parallel to the probe or to the image that is being seen, the better is the needle visibility. The various maneuvers used to optimize the image are the pressure, alignment, rotation, and tilt. So when we press, we reduce the distance from the probe to the target structure so that it becomes more superficial on our screen and the visibility is better. Alignment is moving left and right, up and down, so that we can align the image better to the target structure. Rotation, we can rotate it clockwise, anti-clockwise to make it short axis or long axis or the best view for the target structure. We can tilt also in a right to left, left to right fashion for better identification for the structure. These are the images showing these various maneuvers. So what sliding does, when you slide, you need to identify the target structure. So you slide slowly the probe and go to your target structure. Here I am trying to show a subcostal tab block. So you can see the abdominal muscles here. So for optimizing the needle, there is a tilting that you can use. So if you tilt it right and left, keeping the footprint of the probe stable, you can tilt so that the needle visibility is better and image is better acquired. Kneeling is one of the techniques for needle visibility, and so when you are seeing the needle in an angle, like here it is in an angle, to enhance this angle or make it more parallel to the probe, we kneel the probe. So the probe is tilted towards the needle. It is tilted towards the needle so that the angle to the needle is more parallel to the probe. Coming to injection and delivery of the drug or local anesthetic, we begin with a goal, that is the target. What we need to identify how much volume we need to give and what are the drugs we need to give. We have to be prepared for that first, identify the target structure, and then only decide about injection. One point which is there, that every nerve is surrounded by a tissue compartment or an envelope, and that is what the target is. We have to target the tissue compartment. We should not touch the nerve ever. Enter the target compartment and deposit your drug. We need to deposit the drug in this compartment, which will distend the paraneural and bathe the nerve to give us a desired effect. So I'm just demonstrating this injection of a drug in a tissue compartment. You can see how the tissue compartment is opening up and the nerve is getting bathed. The donut sign, which was usually first thought of being a necessity, is not a necessity anymore, but it has a good positive predictive value of 90% for a surgical anesthesia or an blockade. The factors which need to see for success after injection is the successful drug injection should clarify the nerve border. Drug injections will track along the nerve. If we scan post-injection along the nerve, you can see the drug spreading along the nerve track. The injection should separate the connected structures. The structures surrounding the nerve should be separated with the drug injection. And peripheral nerves are more often get enhanced after injection of the drug. Word of caution. Intraneural injections will increase pain. So whenever, mostly we are using ultrasonographic guided injections when the patient is awake, usually it is done. And if there is a severe pain while injecting, you need to stop, reassess whether you are intraneural or not. There will be increase in resistance while intraneural injections. Expansion, splaying of the nerves will be there. And intravascular, you should always aspirate before injection to avoid intravascular injections. a negative aspirate does not guarantee intravascular spread. So always visualize your needle tip while injecting, and you should see the drug spread while injecting. There are various recommendations and guidelines before blockade we should follow. We always have a checklist before giving a block, whether the site is identified or not, site is identified or not, whether we are doing the right target or not. So we, before starting our injection, we always confirm this once again. Few clinical pearls. Ergonomics is very important because you'll be holding the probe for some time. You need not get stressed and tired while injecting, and hand-eye coordination is proper if your ergonomics is proper. So the second important thing is the anatomy. We have to have a great knowledge of our anatomy so that we can see what is there on the screen. और सब कुछ काला अक्षर भैंस बराबर ना लगे. So we need to keep practicing because practice only makes you perfect. We have a lot of blue phantoms available around which we can use for practicing. Always move either the needle or the transducer at a time. Don't move both the things together. You might injure some structures inside. Inject only when you can see the needle tip, and while injecting, always confirm the drug spread on the screen. You should see the drug spreading on the screen. Highlighting this point, that anatomy, I will only see what you know. So what is the advantage of ultrasound? Why we are discussing ultrasound? Because it gives us a real-time image guidance. It becomes an eye to all our blind procedures that we are using, blind procedures like the landmark guided procedures. It reduces the prick to local nerves. While we were using our nerve stimulator, we used to get a lot of jerks from the patient, which is because of the prick to the nerves. And it can detect intravascular intraneural injections better when using ultrasound. It is altered anatomy. There are a lot of patients, probably 10-20% of the patients. So it helps in altered anatomy also to have a better blockade. And the onset duration and success rate is very high using ultrasound. Thank you. Dr. Shovan?
Hello.
Yes.
Yeah, thanks, Gaurav, for the nice presentation. I think we'll be needing more sessions on this. So that,
yes. Actually, 10 to 15 minutes in covering basics is very difficult. So I tried to cover most of the things. I might have missed few things regarding chronic pain blockade, because chronic pain blockade, we usually use ultrasound and the OPD setup for intra-articular injections, trigger point muscular injections. So they're very commonly used, and very superficial blockade like lateral femoral cutaneous nerve, median nerves, carpal tunnel. All these things are, I think we need to have this more regularly to see what is the use of ultrasound in pain. Thank you.
Yeah, gradually we'll be doing the same participant that gradually we'll be covering each and every chronic pain procedures and everything, and how to do it under ultrasound as well as under fluoroscope, both the things, so that we'll be trying to cover up all the aspects of chronic pain so that we can at least propagate to the new students who are there, so that they can choose pain as a future prospect, because it's just a starting, as I can say, from our state. Now, thank you, Gaurav. Next speaker will be Dr. Ritesh. Hello.
Hello.
Ritesh?
Yeah, I'm there.
Yeah.
Am I audible?
Yeah, you're audible.
Yeah. Thank you, ISSP Bhubaneswar, and first of all, I like to congratulate all the office bearers of ISSP Bhubaneswar for taking this initiative and starting this academic program. And it was a very nice presentation from Nivita madam. And basically, if you see the opening, Gaurav, I will come later on. If you see the opening of our academic discussion, it was from none other than Professor Nivita Pani. So this webinar series from ISSP Bhubaneswar has got a very good start, and it will go further on. And Gaurav, it was as usual a very nice presentation. Now, slightly different from the chronic pain aspect, I'll be talking about total knee replacement, the post-operative analgesia part, because if you see the TKR, it is one of the most common orthopedic surgery which is happening in any of the hospitals. I think everybody will agree with me on this. So I will be talking about a technique which has been innovated by me, and we are getting very good results from this patient. Although I don't have I have not done a RCT to prove my results, but I am happy. My patients are happy. My surgeons are happy, and we are in a process of doing a RCT to substantiate our technique, and we can prove that to the Western world that people from India can innovate a technique and give it to the world. So these are my declarations. Now, why knee surgery? Knee surgery is one of the most painful surgery, and if you see the numerical rating scale of TKR is 5.41, and the pain intensity on first day after surgery after TKR, it is around 6-7. And right now the ERAS concept has come up in everything, starting from your orthopedic surgery to abdominal surgery, everything, it's ERAS. And your surgeons will want that your patient should walk as early as possible post-operative. Okay, so if your patient is not pain-free, your patient is not able to walk. That is very much sure. You can give opioids to make them pain-free, but that ERAS concept is gone. Because if you are using opioids, your patient will not be mobile, will not go back to his daily life as early as possible. So you have to give a very good pain relief to have that ERAS concept. So before going for any surgery, it's not only about TKR, any surgery, you should know where your nociceptors are there. What is the area, which nerve is supplying that area, and you have to block that nerve. So relevant to TKR, the nociceptive nerve endings are extraarticular and intraarticular. The extraarticular, it's mainly the enteromedial skin, because in maximum place, it is a medial parapatellar arthrotomy which is done for a TKR. So your extraarticular is from your enteromedial skin, the subcutaneous tissue, and the medial retinacular complex. And intraarticular is the synovial membrane, the fibrous capsule, the cruciate ligaments, the peripheral part of meniscus, the infrapatellar fat pad, and the posterior part of knee capsule. So these are the place where your nociceptors, knee nerves endings are there. And what is the sensory innervation of knee relevant for TKR? The extraarticular is by the anterior group of sensory nerves, which are from the medial femoral cutaneous nerve, which is a branch of saphenous nerve, the medial retinacular nerve, which is a terminal branch of nerve to vastus medialis, and the infrapatellar branch of saphenous nerve. So you have got the anterior group of nerves, which is mainly the saphenous nerve and the nerve to vastus medialis. And the intraarticular is from the posterior group of sensory nerves, which is from the popliteal plexus. And the popliteal plexus is formed by the articular branches of the tibial nerve and the posterior branch of obturator. They unite. Both of them form the popliteal nerve plexus, and which provides the innervation to the posterior knee capsule. Because I don't have a study don't have a study in my presentation right now, which was published this year in RAPM, where they have done a cadaver dissection, and in almost 100% of the cadaver, the posterior capsule was supplied by the articular branches of the tibial nerve and the posterior branch of obturator. So if you are blocking these two nerves, the popliteal plexus, your posterior knee capsule analgesia is achieved. So what are the nerves which are relevant for postoperative analgesia in TKR? Saphenous nerve and nerve to vastus medialis, which takes care of the extraarticular part, and the intraarticular is from the tibial nerve and the posterior branch of obturator, which forms the popliteal plexus. Why analgesia for TKR is a problem? Because till now, we don't have any gold standard technique. For me, modified 4-in-1 might be gold standard. For you, epidural might be a gold standard. For other person, it might be a adductor canal with a selective tibial. So till now, we don't have a gold standard block, because every block has got a positive aspect and a negative aspect. So what are the nerve block options for the extraarticular or the anterior? It's from the femoral nerve block and the adductor canal block. But if you are giving a femoral nerve block, your analgesia will be perfect, but your patient will not be able to mobilize. So your ERAS concept is gone. Adductor canal block, advantage is preservation of quadriceps strength, and you have got almost equivalent analgesia as compared to the femoral nerve block. So people are using adductor canal, combining other block for the posterior aspect. And for the posterior aspect, you have got a sciatic nerve block, the selective tibial nerve block, the IPAC block, which was innovated by Sanjay Sinha, and a LIA, which you can tell your surgeons to infiltrate the posterior capsule to give you a intra-articular analgesia. But if you are giving a sciatic nerve block, the patient will have a foot drop and they will not be able to mobilize. Selective tibial, same thing, the sole of foot thumb might interfere with your ambulation. Okay, so people have combined adductor canal block with the IPAC block, or adductor canal block with the tibial nerve block, to combine both the extraarticular and the intraarticular aspect. So we came up with a simple solution. Why not give a single injection and block the extraarticular and the intraarticular both in a single injection? So in 2018, we came up with an ultrasound guided 4-in-1 block, a newer single injection technique for a complete post-operative analgesia for knee and below knee surgery. And these were the nerves which we were blocking, which were the saphenous nerve, the nerve to vastus medialis, the tibial nerve, and the posterior division of obturator. And these are the nerves which are required for your knee and below knee surgeries. And this is the anatomy which we utilized to get this block. Now, if you see, this is your femoral triangle, this is your popliteal fossa, in between is your adductor canal. Your artery runs through the adductor canal. Near the adductor hiatus, it dips and becomes the popliteal artery. And you have the nerve to vastus medialis, the saphenous nerve, the posterior division of obturator. They are running, and the posterior division of obturator, it enters the popliteal fossa through the adductor hiatus. The saphenous nerve runs in the adductor canal and becomes superficial and provides cutaneous analgesia to the medial aspect of the leg. Now, if we thought if we deposit the drug at this level, just before a place where the descending genicular artery goes off the superficial femoral artery, this drug might spread up and block the nerve to vastus medialis and the saphenous nerve, and along with the superficial femoral artery, it will track down and block the popliteal plexus, that is the posterior division of obturator, and the sciatic nerve. This was the concept which we thought, and we started giving injection at this level. And we found a good analgesia post-operative in our patients. And we did when we did the first study, when we did the first injection, we did a dye study by using a C-arm. And we found a good spread of drug to the proximal adductor canal and a spread to the popliteal fossa. In the first case which we did, when we injected, we took a dye along with the drug, and we saw that this drug was spreading nicely to the proximal part of the adductor canal, and posteriorly it was going to the popliteal fossa. And when we were almost 6 months, 7 months in our technique, this publication in RAPM gave us a boost in 2017 December, because we started our study almost in January 2017, and we published in January 2018. So in December, when we were ready with our publications, everything, this study in RAPM gave us a boost. That is, spread of ultrasound injected from the adductor canal goes to the popliteal fossa and blocks the genicular branch of the posterior obturator nerve and the popliteal plexus. And what they found, there was a good spread of drug in the popliteal fossa. And this was the same place where we were doing our injection. So this study gave us a boost that we were in the right track. But almost when we had published this ultrasound guided 4-in-1, after almost a year or so, many of our patients, they started complaining pain in the medial aspect of the knee. And it was not a superficial pain. They were telling that it is paining in the medial aspect. Then we again went back and started studying the different publications which were there, different articles. And this article, the anatomical study for the innervation supply of the vastus medialis muscle, in maximum patient, the nerve to vastus medialis was never a part of adductor canal. It used to run in a different bilayered fascial envelope. And the medial aspect, the medial retinacular complex, is supplied by the terminal end of the nerve to vastus medialis, which is a medial retinacular nerve. And we thought that the patients who are complaining pain in the medial aspect, most probably the drug which is spreading proximally to the adductor canal is not blocking the nerve to vastus medialis, because the nerve to vastus medialis, in maximum patients, they are not part of the adductor canal. So why not we block the nerve to vastus medialis separately? And there came the concept of modified 4-in-1 block. The modification was a extra blockade of the nerve to vastus medialis by using the help of nerve stimulator. And this is the way we do it. The patient position, either you can place the patient in a frog-like position, or you can just do also in a supine position. You place your ultrasound machine in front of your, it should be, ergonomics should be perfect. It should always be man, patient and machine, so that you don't have any problem when you are doing your needling. It's usually an in-plane needling from lateral to medial. And this is the sono-anatomy view which we want. The vastus medialis in the lateral aspect, the sartorius in the medial aspect, and the superficial femoral vessels in between. And this is the descending genicular artery, which I was talking about. Just proximal to it, this is our injection point where we deposit the drug. Okay. And the other drug which we deposit to block the nerve to vastus medialis is usually at this aspect. The needle comes in plane. First, we locate the nerve to vastus medialis by using the peripheral nerve stimulator, and we deposit around 5 ml of drug here. The same needle goes just perivascular, just above the superficial femoral artery, and we deposit another 20 ml. So how we identify the injection point? The probe is placed in the medial aspect at the medial femoral condyle. We start scanning up. As we start scanning up, you see the superficial femoral artery coming out of the adductor hiatus. You can see the superficial femoral artery. You can see the descending genicular artery. This is your medial, this is your lateral, this is your medial. As we start scanning up, we see the superficial femoral artery coming out of the adductor hiatus. This is your vastus medialis muscle. This is your sartorius. This is the descending genicular artery which comes out and runs through the vastus medialis muscle. And this is the place just proximal to the point where the descending genicular artery comes out. This is the injection point. This place is our injection point. This is the vastus medialis muscle. This is the sartorius. This is the superficial femoral artery. And this place is our injection point. So this is the way we do it. We do a in-plane needling by using the neurostimulation of nerve to vastus medialis at 0.4 to 0.5. And this, you will see the vastus medialis contraction. Okay. At the medial aspect of the leg, you will see the vastus medialis contraction. And if it's present at 0.4 to 0.5, it means you are catching the distal, the terminal branch of nerve to vastus medialis. This is the vastus medialis muscle. We deposit around 5 ml of drug here. So one nerve is blocked. That is the nerve to vastus medialis. Now this same needle will run to the perivascular to the superficial femoral artery. You can see the two branch of the saphenous nerve, the infrapatellar branch and the tibial branch. You can very well appreciate the two branch of the saphenous nerve. These are the two branch. Here I will deposit around 20 ml of drug, and as I start injecting, the artery will start dipping and this space will start opening up. You can see the two branch, and after injection you can see the drug spread. If you are in the right plane, if you scan proximally, the drug will go almost, you can see the drug almost to the start of adductor canal. I am scanning up. This is the sartorius muscle. This is the vastus medialis. This is the adductor longus. And you can see the drug just lateral to the superficial femoral artery. I am just scanning up. It means I was in the right plane. You can see this is sartorius. Almost I am reaching to the start of adductor canal, and you can see the good amount of drug, and you can see the two nerves. You can see the two nerves which are part of the adductor canal, and I am almost reached to the start of adductor canal. It means the injection was in, if your injection is in right plane, you can, if you start scanning up, you can see the drug lateral to the superficial femoral artery till almost to the start of the adductor canal. So what are our hospital protocol in TKR? Preoperatively, we give a tap paracetamol 1000 milligram orally. Tap pregabalin is 75 milligram. HS is must because there's some amount of chronic pain component in these patients. Intraoperatively, our maximum patients are done under spinal anesthesia. Only when there is a contraindication to spinal, we go for a general anesthesia. Dexamethasone 8 milligram IV stat at induction. Maxelf 1 gram stat at induction, which I used to use, but recently we have stopped using it. Paracetamol 1 gram intraoperatively, diclofenac 75 milligram in 100 ml NS, and these patient gets ultrasound guided modified 4-in-1 block after giving spinal, and it is pre-operatively. Okay. Post-operatively, next day, usually our patients stay in our surgical ICU overnight for observation and monitoring. Post-operatively, paracetamol, TDS, diclofenac, BD. Next day, we repeat one more time ultrasound guided modified 4-in-1 block in our surgical ICU, and then these patients are shifted back to the ward. So the concept is multi-modal analgesia. It's not that if I am going to give block the rest of the NSAIDs, analgesic, if you are stopping, you might not get as good pain relief if you combine it. So always go for a multi-modal analgesia concept, because obviously I'm not going to talk on the pain pathway part. Every pain block has got a different place in the pain pathway. Paracetamol has got a different place in the pain pathway, and diclofenac has got a different place in the pain pathway. So always practice multi-modal analgesia in all of your patients. So this is the patient which we did recently. It's hardly 4 hours after surgery. After his spinal veered off, he is walking pain-free. He's walking pain-free. And to be very frank, I was also, because the earlier it was maximum 6 hours we have started, but this was 4 hours and he was very comfortable walking. And this patient, he's a 75-year-old surgeon, 75-year-old doctor, or he's a IMA member, and 6 after surgery, he was so comfortable, he was walking pain-free in himself. And post-op, and on third day, see the third post-op day, he is climbing stairs himself. Sorry. This is the third post-operative day. He is walking stairs, and I told him to just give a feedback. So you can follow me on my YouTube channel. There are around 40 videos, all different videos of ultrasound guided blocks. And you can see the full series of modified 4-in-1 block in that YouTube channel. And thank you for your patient listening. Thank you to ISSP Bhubaneswar for giving me an opportunity to speak in this inaugural edition. Thank you.
Thank you, Ritesh. It was a nice presentation indeed. And we'll be having more sessions like this where we can listen to regarding the different kinds of blocks and how we can make the patients pain-free post-operatively, and also regarding chronic pain. So as we have decided that we'll be doing this kind of webinars twice a month, almost in 2 Sundays. It will be a regular event. So we'll request all the participants to convey this message to everyone, so that from the next session onwards, more number of doctors who are available in Odisha, at least they can attend the session. Now I request Prasanna sir to speak few words because he's been since the starting. So you are the mentor from whom I have learned everything. So
okay, thank you, Subhan. Am I audible? I think.
Yes, sir, you are audible.
Yes, sir. Yes, sir.
Okay, thank you, Ritesh. Thank you, Gaurav. All nice and unique presentation. Okay, as this, as I want to speak something little different. There are a lot of participants now. I think there are 40 participants right now. And what is important, this ultrasound machine is not available in many places. You know, all these participants probably they are not exposed to ultrasound machine. So that is the only setback in our setup in Odisha. But they must learn more and more. They must go to a center where ultrasound. Then only they can use the handle or vein ultrasound. If they have applied, it takes time to get it. So they should be trained in some places. Maybe Gaurav or Ritesh, you can start, those who are interested, you can start using this ultrasound. This ultrasound being a kind of non-invasive, or unlike you can do it anywhere, by the bed, on the operating table. So that is, other than those EA-guided, X-ray guided things, you have limitations. But this ultrasound has revolutionized our, particularly acute pain management. And I am sure we need more ultrasounds around so that people can do practice and this thing. So Gaurav has presented nicely how to handle the ultrasound machine. And Ritesh, I just wanted to have a little word. For this TKR, yes, you are doing a good job and your presentation is nice. Recently, I have been to USA and there is one of my students, he wanted to do some patients that to be done in Apollo Hospital. Dr. Siddharth Manti knows. So we also imported some forms from Israel and did this block with a continuous drug infusion for 48 hours. Those patients, still results are not yet, the PA studies is incomplete because this pandemic. We wanted to also understand the level of the drug in the blood and many other parameters. They are all in the cells because of this pandemic. That report may come. It may take some time, 1 year. Some of my students in Apollo, they were taking up this, and I also saw 2-3 patients. They are also very painful. But as of now, many of us who do TKR, like me, I go for epidural because of the limitations for availing this drug. And yes, like, you know, even epidural is a routine deal. Previously, it was like a technique which was very few people able to they do this thing. But now everybody knows epidural. So like that, ultrasound probably everyone will be doing in future. But they need to be exposed, to be trained to handle this machine. And I will request you to leaders to train more people, those who are volunteers. And very nice. Yeah, thank you, Shobhan, for your effort and continue your work. And this is the occasion. I just telling you, I have got some few extra needles for you. I have kept it for you. I will give it to you at some other time. Just I am telling you for a procedure. So thank you. Let others speak or ask questions to the speaker. Okay.
Thank you, sir, for the nice words. I'll ask Dr. Siddharth if he is here. Hello, Dr. Siddharth, are you here? I think he has left. So it was a nice. Hello, Dr. Siddharth. I think he's not there.
He's not there. Maybe.
Okay.
Okay.
No, he's not. Okay, we'll wind up this session. And before winding up, I'll be thankful to the persons who have helped us.
Just a minute, Shobhan. Shobhan, if I just a minute, can you give me another minute?
Yeah.
Yeah. we for last year, from last year onwards, we have started Aura Fellowship program in a hospital, Academy of Regional Anesthesia Fellowship. It's a 1-year fellowship, in-house fellowship, and 2 seats are available. And the 2 fellows are already continuing their fellowship. For next year, we have already done advertisement, and 19th December, we are going to hold a Zoom interview. So anybody who is interested can send his CV in my mail ID, and the session will start from 1st of April 2021. It's a 1-year fellowship, in-house fellowship, and you will be paid a stipend. So anybody who is interested, wants to take ultrasound as the pain management as his future career, is most welcome to apply and join this course. Thank you.
Yeah, very nice, very nice. Okay, good job.
Thank you, sir.
Okay, it's indeed a nice part. Those who are interested can join. Now, these sorts of webinars will be continuing henceforth, and the next is on 20th of this month. So, and the topics and everything will be sent to you by WhatsApp and mail. Those who have participated in this seminar, thank you all. And I'll be thankful to Fujifilm Sonosite for technical support, and Johnson & Johnson company people for helped us in the technical part.
And also Anesthesia TV. Yeah.
Yeah, I'm coming to, and Anesthesia TV, and Mr. Rahul Chaube for spreading the message via YouTube and Facebook to many people who are not directly linked to us through Zoom. And I hope that in future we'll go ahead with lots of program like this. I'll be thankful to all the speakers and the chairpersons who have attended this session, and the participants and all our sponsors who have helped us in this session. Thank you very much. We'll wind up with this. Thank you.
Thank you. Thank you, Shovan. Thank you. Bye-bye. Take care. Shalom. Stay safe.
Yeah, I find many new names and really surprised. Good. All are welcome.
Thank you, sir.
Thank you.
Thank you, sir. Thank you.